I will introduce you, Prof, in two seconds, and Prof. Shalabi, and they will leave the floor to you. All right?
Okay.
Tonight, we are introduce you, Prof, in two seconds, and Prof. Shalabi, and they will. Since 2022, we are taking a different direction for our teaching, and we are making it a modular training and modular teaching. And each webinar taking the symposium, like for a cohesive lecture. Like today, we have a elite bunch of panelists, and chaired by Professor Mirhat Chalabi. He's a professor of anesthesia and intensive care and the subspecialty in obstetric anesthesia and the special interest in ERAS. Professor Mirhat Chalabi is honoring us tonight by chairing this session, and good luck. Thank you so much.
Thank you, Dr. Saad Mahdi. It's an honor to be among this elite group of experts in anesthesia. And I'm really honored to be among this nice group, which gather people older like myself and John, if you allow me, John, to say you're an old man like myself. And,
yes.
and we have other younger generation who are very enthusiastic and very capable of giving this lecture. We will start by my dear friend John Doyle, Professor John Doyle, who's in the Department of General Anesthesiology, Clinical Clinic, Cleveland Clinic, and clinic learner of Western Reserve University. Dr. Doyle, Professor Doyle received MD degree in 1982 and his PhD degree in the biomedical engineering in 1986, both from the University of Toronto. He received his Canadian board certification in anesthesia in 1986 and the American certification in 1989. Dr. Doyle has a long-standing interest in ENT anesthesia and difficult airway management, as well as an interest on the use of technology in medicine. His research has been supported by a number of funding agencies and holds positions on a number of editorial boards. Professor Doyle is the past president of both the Society for Airway Management and the Society for Technology in Anesthesia. He has received the clinical teaching awards on 4 occasions, and he's a very well-known speaker to all of us here in the Middle East, and I'm honored to be one of his friends, and I've encountered him and met him so many times in very interesting discussions and lectures. So the floor is all yours, and my dear friend John Doyle is going to talk to us about extubation of the difficult airways. It's all yours.
Good. Let me take care of some technical matters here because I want to make sure you're able to see the slides. And do you have a good view there? Let me do, I have to go to share slides. So let's go for go to.
There is a window.
I don't see the share slide option here.
You can close the window in the middle of the slide, please.
Close this window?
Yeah, this window, small window in the middle of the slide. You can close that one or minimize it or something like that. In the bigger slide, in the slideshow, there's a window including yourself.
Yes, I may have to reboot or something because
No need.
No, okay.
No need.
None or blur or whatever.
Okay, can you see this one?
We see that, but we see you again in the middle of the slide. So you in the top of that slide, in the top of that window, in the middle of the slide, there is an X on the top right.
Yeah.
Right, X, okay.
Small
But
X
now
is
it has eliminated, it has
You've done it.
eliminated the PowerPoint.
That's fine. But just say, you close that one again, please.
Let's see what's happened here.
Or make escape.
No, no, it is not.
Okay, you see above your video, there is a small X in the middle of the screen, not on the right of the screen. In the middle of the screen, there is a small X. You can close that one. Take your time, no rush.
Oh, well,
Okay, you come back again, go to the video and stop.
right. It's unfortunately, it's not showing up on my screen here. I may have to X out and start again.
Okay.
Let's try that. Sorry for this technical problem.
That's
It's
fine. That's fine, Prof. No problem.
yeah. Close the window. I'm going to quit Zoom and re-enter.
Excellent. Unmute, John.
Okay. And then what we have to do is find my slide again. So I will launch PowerPoint again. Here is best practices.
Good job. Well done.
Okay, is that better?
We need to see the slideshow now. It is two slides.
Yes, can you see it now? I'm sharing my screen.
We need to see the slideshow. We have two slides now, two screens now.
Yes, and when I go to
Presenter view.
Ask him not, and don't go in slideshow, just go in full window, because in slideshow, here you will see both the slide and your vision will not be clear. So we want only one slide. In that case, you have to show the only slides. Don't go in slideshow mode. So
end slideshow.
yeah, end slideshow, only slide. And then here, just one, that
one more to do.
That one, yeah. That one.
No.
No.
Is this good?
No, it's not good. You have to stop slide slow from your presentation. You stop slide slow from your presentation. Yeah, now it's correct. Now it's good. Now.
Okay.
Little bit right.
This one here?
I think so.
Yeah, this one is okay. Now it needs to get enlarged. So just enlarge it. Just make it 125%, 125%.
Oh, okay.
125%. Little less.
125. I can do that.
125.
125.
Yeah.
Is that better?
Little better. Can you make up to 150?
There's a sign for a slideshow, bro. Under the.
I know it's not. The slideshow icon doesn't work. What happens is it produces two.
No, I think in your computer somebody has set the presentation in slideshow mode. You need to stop it from that part.
Yeah.
Yeah, slideshow. I mean, that has to be stopped. It will come. I just tell you from where it will come.
Our apology for that technical point, guys. So this.
So
let's. Can I suggest we have Rajesh first, if he's ready?
I think that might be the best solution.
I'm ready.
Work on this.
I just tell you,
you can go ahead and I will do it in video editing. No problem.
Yeah. Let's shift to Rajesh while can have
Dr.
some
Boyle,
time
Dr.
to
Boyle,
sort.
Dr. Boyle,
Go on.
just go to your slide. Go to
Go
your
on.
slide. On extreme left,
Yeah.
there are three dots. There are three dots. There are three dots.
I will correct that in video editing, Prof. No problem.
The
Three
three
dots.
Go on.
Yeah, in that you go and in presenter
I will do
view.
that in the video editing. No problem.
In
It
presenter
will
view,
be
you have to
corrected.
stop the presenter view. You have to stop the presenter view. You have
So
to
stop it. Okay.
You stop the presenter view. You are using presenter view. You stop.
You can go ahead and I will do that in the video editing.
Okay. Stop video. I have stopped the video as requested.
No. Stop the presenter view. You are using presenter view. Okay.
Right. But it wouldn't allow me to switch. When I do that, I get the double presentation, which I don't.
Don't worry. You can go ahead and I will
Yeah.
correct it.
That's
Can
okay.
Okay.
Yeah.
Let's start, please.
We'll start
Yeah.
with Rajesh.
Yeah.
For some reason in mine, it's gone into the double mode and it wouldn't allow me to do.
Dr. John, Dr. John, just can you just switch on your video? I tell you what you have to do.
Switch
Dr.
on the
John,
video. Okay. So
Yeah,
I'm
switch on
starting
the
video.
Yeah. Dr. John,
Video's now
just
on.
on your extreme left in your slide, on your extreme left,
Yeah.
there is a three dots. The three dots. You have to find. You have to change your slide in presenter view. You have to stop the presenter mode.
Okay.
Presenter mode.
Good.
Did you get that?
So stop presenter view.
Now you go and come here. Now again come to the extreme right down.
Okay.
Extreme right down. There is one called presenter mode. Now click on presenter mode. I cannot see your arrow.
Presenter mode.
Just the second one from right or third one from left. The only single one.
It says read. I have
Normal. Right. Next. Yeah. Click that.
reading view.
Yeah.
And then I've got slideshow.
Yes, that's all.
This one.
This one here, zoom level.
Yeah.
No, slideshow.
Okay, when I click on slideshow,
It's
that
okay.
doesn't work.
Now you go ahead.
You can go ahead. Simply, you can go ahead and I will do that. I will correct it.
Okay, so are you guys happy for me to proceed?
Yeah.
Of course, we are very happy for you to proceed,
Okay,
Professor.
well, sorry for all the technical trouble. I think the origins of the trouble might be me having attempted to apply a second monitor. But in any event, let's get started with our discussion today called Tracheal Extubation, Examining Best Practices. Our objectives are to understand how tracheal extubation can be perilous, problematic for the patient, understand the use of airway extubation catheters, understand post-extubation stridor and its management, and understand how drugs can be useful agents in facilitating tracheal extubation. The outline here will cover some definitions, including extubation weaning, looking at weaning criteria, some extubation protocols, and some extubation styles. For example, many of us are familiar with weaning criteria that apply in the intensive care unit, and some of these criteria may include such things as the ability to generate a vital capacity of 10 to 15 mLs per kilogram. We may want the arterial oxygen tension to exceed 60 millimeters of mercury with a fraction of inspired oxygen under 40, stable vital signs, and things like that. So these are some of the things we're going to be taking a look at. And we're going to be concentrating on extubation because it can be particularly perilous in the fragile patient. One of the things we want to do before extubation takes place is ensure there's proper equipment available, monitor the vital signs of the patient, ensure full reversal of paralytics, something that's now more popular with Sugamidex, and the use of the train of 4 monitoring to ensure that the train of 4 ratio exceeds 0.9. Sometimes gentle sedation during extubation can be helpful, and we call this pharmacologically facilitated tracheal extubation, and we'll have a chance to talk about that in the context of both remifentanil and dexmedetomidine. When you extubate, of course, you'll want to make sure that you have a variety of rescue equipment available, such things as an oxygen source, suction, face masks, a laryngeal mask, airway, or other supraglottic airway that can be very useful if you need to support the patient when extubation is perilous, pulse oximeter, cardiac monitors, CO2 detectors, and so on. You want to make sure that when you extubate, the patient is able to protect their airway. So we need the appropriate level of consciousness as assessed by the Glasgow Coma Scale. We want to ensure that they have adequate airway protective reflexes, that they're able to cough and swallow, that vocal cord function is good, and secretions are adequately managed, and that can be particularly important to have good suction. Can the patient pass a breathing trial? You may want a spontaneous breathing trial between half an hour and 2 hours with a low level of CPAP, for example, 5 centimeters of water, or a low level of pressure support, such as 5 to 7 centimeters of water. You'll also want to take a look at arterial blood gases, hemodynamic stability, and the subjective comfort of the patient to ensure that that they are not having a lot of difficulty. For those of you who like numbers, we want the respiratory rate under 35, typically the vital capacity to exceed 10 mLs per kilogram, the negative inspiratory force exceeding minus 20 centimeters of water, tidal volume over 5 mLs per kilogram, minute ventilation under 10 liters per minute, and thoracic compliance where measured over 25 mLs per centimeter of water, but thoracic compliance is not typically measured in ordinary clinical practice. Now, we are grateful for the Difficult Airway Society from the United Kingdom to have offered us an algorithm for managing extubation. In previous years, a lot of emphasis went into algorithms for managing intubation. In the case of extubation, the DAS, the Difficult Airway Society, has come up with this basic algorithm. Step 1 is planning your extubation. You want to identify risk factors such as obesity, risk of aspiration, a known difficult airway. Step 2 is to prepare for extubation. And for this, you'll want to determine whether the patient is at low risk, and that typically would be fasted and uncomplicated airway, no general risk factors, or the patient who is at risk, for example, at risk of aspiration or ability to oxygenate may be uncertain. So you have 2 different algorithms when extubation takes place in step 3. The low risk algorithm I'll take a look at in a minute, and the high risk algorithm, which is identified here in red. And then step 4 is extubation care. You want to recover in a high dependency unit or intensive care unit. You want to hand over to the receiving clinicians a report about the patient and your plan. Now, for the at-risk algorithm, as you can see here, there's a lot of planning involved, and the key question is it safe to remove the tube? If it is safe, then you want to do awake extubation, or you can extubate, if it is safe, using some techniques such as the use of laryngeal mask exchange, remifentanil technique, or airway exchange catheter. We'll have a chance to talk about some of these. For example, in the laryngeal mask exchange, the idea here is that you take out the endotracheal tube, you put in a supraglottic airway, and then you proceed to wake up the patient further with the supraglottic airway in place. Remifentanil I'll talk about in a minute as well, and airway exchange catheters I'll talk about. But if it's not safe to remove the tube, it may be necessary to postpone extubation to get better criteria, or in some cases a tracheostomy. And then finally after that, you've got the post-extubation care. One of the challenges that we face in the intensive care unit is a patient who gets agitated and extubates themselves or pulls out their various lines, such as IVs or their arterial line. And this is something that typically is handled by gentle sedation. And it's popular in the intensive care unit to sedate patients with, for example, propofol, or sometimes remifentanil, or sometimes dexmedetomidine. The choice is yours. But to prevent self-extubation, you want to avoid inadequate sedation, which can place critically ill patients in danger of self-injury from self-extubation. Critical care nurses can use clinical protocols to help manage agitation in intubated patients and prevent self-extubation. Now, another technique is extubation following placement of a reintubation catheter, and this is the Cook tube exchange catheter, which is placed down the endotracheal tube prior to removal of the endotracheal tube. And here is an example of one. This is an image from the NAP4 study showing a patient who has the extubation catheter in place and then being oxygenated in this manner. So if you need to reintubate because the patient gets worse, you can reintubate using the exchange catheter as a guide, railroading the tube over the exchange catheter. So here's an example of the routine use of a pediatric airway exchange catheter extubation of adult patients who have undergone maxillofacial or major head surgery. And this is from Critical Care Medicine 2004. And you can see in these patients, if they have to be re-intubated, then what you can do is pass the endotracheal tube over the exchange catheter. Also, bear in mind that you can insufflate oxygen through this to provide oxygen to the patient. And if needed, capnography can be done using the same device. Now, when it comes time to extubate, there are a variety of extubation styles. First, there's cowboy extubation, where we just go for it. Then there's pharmacologically facilitated extubation, typically using dexmedetomidine or remifentanil, sometimes propofol. And then extubation following placement of a reintubation catheter that I just mentioned. What we want to avoid is a vicious cycle where the patient is intubated for agitation and then agitated from the intubation itself. So here's an algorithm for breaking this cycle. Is there a reason to suspect the patient has respiratory insufficiency? If not, then you can stop sedation, extubate when the patient gets agitated or perhaps a little bit before that. But if there is reason to suspect the patient has respiratory insufficiency, then you can extubate, for example, using dexmedetomidine facilitated extubation. And this dexmedetomidine would typically run at 0.2 to 0.7 micrograms per kilogram per hour, titrated to a level of sedation score such as the Richmond Agitation Sedation Scale, which you typically want between 0, -1, or -2. And if the patient passes the breathing trial, then you can extubate and wean off the dexmedetomidine. If they fail, you want to find out what happened. And that can involve chest x-ray, clinical assessment, chest ultrasound, and treat any pulmonary problem. So this is the vicious cycle you want to avoid. But if all is well, you can stop the ICU sedation, do no attempt at a spontaneous breathing trial, and extubate when the patient becomes agitated or approaching agitation. If agitation persists, you can give medications like benzodiazepines or dexmedetomidine. But skipping a spontaneous breathing trial could be a problem if the patient actually wasn't ready for extubation. So in young, healthy patients without a lot of comorbidities, you can just do cowboy extubation by just going for it. But in many patients that are more fragile, a more nuanced approach is needed. And this can involve sedation, as I've mentioned. Clinical uses for sedation involve procedural sedation, for example, for insertion of a chest tube, ICU sedation to support patients that are ventilated, and finally, to support extubation anxious or agitated patients. Pharmacologically facilitated tracheal extubation might be using remifentanil, dexmedetomidine, or another agent. It incorporates a spontaneous breathing trial, and you extubate when extubation criteria is met, and then you wean off your sedative. You want to assess for extubation readiness, and that means that remembering that ventilator weaning and extubating are two different processes. You identify patients for extubation based solely on criteria. That will fail if you just rely entirely on clinical criteria. It will fail in many cases because you need numbers as well. Predicting patient readiness is based on a number of physiologic variables. No single parameter can actually predict which patients are ready to resume spontaneous breathing. Hence, the information I presented earlier in that regard, such as weaning criteria, such as shown here. Various weaning criteria have been published, and this can be useful for determining under what conditions a fragile patient can be extubated, particularly in the ICU, or particularly after a long case in the operating room in a fragile patient. Here are some indications for extubation. As I said, no weaning parameter is completely accurate when used alone. For example, you want the partial pressure of oxygen to fraction of inspired oxygen to be greater than 200, and a tidal volume exceeding 5 mLs per kilogram, respiratory rate under 40 for the weaning threshold as examples. So these are examples of some of the indications for extubation that you may want to use in your particular intensive care unit. Failure can occur, and if the patient is diaphoretic, showing nasal flaring, increasing respiratory effort, tachypnea with increase in tachycardia with an increase in heart rate more than 40 breaths per minute, or laboratory criteria where you have acidosis under 7.32, increase in tidal CO2 greater than 10 milliliters of mercury, SpO2 declines more than 5%. These are all examples where failure can occur or be imminent, and it shows you the importance of clinical assessment and a laboratory assessment. But remember that failure is a bruise, not a tattoo. If you fail at time of extubate, you may have to support them with respiratory techniques such as reintubation or continued positive airway pressure or BiPAP, and proceed once again carrying out the algorithm. In the intensive care unit, one approach would be to determine disease resolution and consider other factors. For example, a patient whose pneumonia has resolved, identify candidates for a spontaneous breathing trial and perform that breathing trial, identify candidates for extubation, and then carry on from there. Some extubation wisdom from the ages: don't take out anything from the patient you can't put back in. Be prepared to reintubate. If in doubt, extubate wide awake. A person who is bucking on the tube may not necessarily be safe to extubate. You can get into trouble even when extubating the awake patient, and always have a backup or rescue plan, as I've alluded to earlier. Here's a study from a journal called Pediatrics. Low-dose dexamethasone facilitates extubation among chronically ventilator-dependent patients. This reduces edema and can be useful in the pediatric population. Now, there is on the internet an Anesthesia Ideas discussion group that discusses various ideas for extubation and other ideas related to anesthesia. And I'd like to show you some of the wisdom that has been around. Now, over 10 years ago, there was a posting about deep extubation, and the guy posting the question said, can anybody provide a method they prefer for deep extubation in patients? And he goes on, being a resident, I've had some days go much faster than others when treating different methods, just wondering what others in the real world do. And this resulted in a number of comments. Here is from James Ducanto, who is well known in the airway community in the United States. He suggests that we intubate through a supraglottic airway. He recommends the AirQ supraglottic airway, leave it in place, then extubate the trachea when spontaneous ventilation occurs at the end of the case and allow emergence with the air tract. So you intubate through a supraglottic airway, and then you extubate the trachea when spontaneous ventilation returns, but you still have the supraglottic airway in place, and then you take that out later. So that's one method. This guy from Guy's in St. Thomas Hospital, Imran, he suggests a low-dose remifentanil infusion, about 0.1 micrograms per kilogram per minute. Wait for them to start breathing spontaneously, then gently extubate. They hardly ever cough and continue to breathe. And in fact, this technique for me works very well in ENT patients where we want to avoid them coughing at the time of extubation. If they cough at the time of extubation in ENT cases, you can get hematoma formation, particularly with thyroid and parathyroid surgery. And so this can be very useful, and I use it almost all the time. My friend, Paul Kempen from the United States, he has a particular method he's developed which works very well, and I'd like to bring that to your attention. He says that he's been doing this for years while supervising residents. He often has patients extubated and breathing with a simple oxygen mask before the bandages are complete. And he suggests that this avoids bucking, coughing, desaturations, and so on. So let's take a look at the technique. He says, deflate the endotracheal tube cuff while the patient is asleep. Lidocaine installation goes into the endotracheal tube, and then with the cuff down, it will go around the cuff. Then you reinflate the cuff, and the lidocaine around the cuff will provide anesthesia. The patient then can be emerged and extubated without knowing the endotracheal tube is in place, much like after LTA, the atomizer that's sometimes used. He goes on to say, allow the patient to undergo relaxant reversal and resume spontaneous ventilation. Test for tracheal anesthesia by rapidly inflating and reinflating the cuff and look for changes in respiration. And then if there's no reaction, remove the tube at 0.2 to 2 Mac, depending on your preferences. There's typically no change in respiration, and you now have an extubated patient, irrespective of anesthetic depth. Some caveats that he would remind you of: lidocaine allergy, aspiration risk, and full stomach are the only clinical contraindications. The less the endotracheal tube is inserted beyond the cords at extubation, the less the amount of the trachea needs to be topicalized, increasing success rates. And 1% solutions of lidocaine are typically effective, but stronger solutions may be needed in smokers or individuals with thick secretions. And I typically use 2% lidocaine in such a setting. Be sure to inject the lidocaine down the endotracheal tube and not into the circle system. And of course, that's kind of obvious. And he goes on to recommend slow installation of 5 cc's of 1, 2, or 4% lidocaine before relaxant reversal or lightening the anesthetic depth if immobility is important, such as the patient in head pins, or for example, in the cases I mentioned for ENT anesthesia, where hematoma formation can be treacherous. He goes on to make some hints. The lidocaine only lasts about 20-30 minutes, so don't install it too early. If extubation is performed too soon before the end of surgery, you may need to provide mask anesthesia for some time, ventilating the patient. And he points out that smokers may require 4% lidocaine because of thick tracheal secretions. Another hint that he provides is that start with patients with good airways and good health until you gain experience, or just to see how it will aid. So in your ordinary cases, for example, your arthroscopies and orthopedic surgery, try it in these cases to get some experience. So this is something that he recommends. Now here's a comment from Terry Weber, and he says he appreciates all the hints for the best technique for deep extubation. And he said several partners were a fan of this technique, but they always ended up with laryngospasm or an airway disaster. And he says deep extubation should really not be required to wake a patient up without an inordinate amount of coughing or bucking, a term I hate. And the tales of patients coughing and bucking, bleeding to death, or exploding vessels in their head are, for the most part, stuff of lore, part of lame anesthesia. Now let's go on. Here is Sandy Hancock, well known from Australia. What is the best method for deep extubation? And he writes, for what it's worth, I almost extubate awake, almost always extubate awake. With a decent slug of opioid on board, most patients just open their eyes when you call their name and open their mouth when you ask. And there's nothing more elegant than that. And remifentanil works very well in this setting. Now, finally, I'd like to bear in mind that there are some potential complications following extubation: laryngospasm, stridor, pulmonary aspiration, upper airway edema, sore throats, and so on. Post-extubation stridor can be a special problem, and it is the noisy inspiration from turbulent gas flow in the upper airway, often seen in upper airway obstruction. It's potentially serious and always commands attention. So stridor is a symptom, not a diagnosis or a disease, and the underlying cause of stridor must be determined. Here's an example of a foreign body that this pediatric patient had aspirated, and there are maybe other things that lead to stridor, and that might include vocal cord edema, tracheal compression by a tumor, and so on. Here is a photograph of an electrical wire stuck in the larynx of an infant at the level of the vocal cords. The wire was removed at laryngoscopy, and interestingly, the child presented with minimal stridor. Here is subglottic stenosis in this child. Here, this child could present with stridor, and treatment options include watchful waiting, tracheostomy, anterior cricoid split, laryngotracheal reconstruction, and cricotracheal resection. Remember that the triangular aperture of a normal infant larynx is about 7 by 4 millimeters, an area of about 14 square millimeters. When intubation or an upper airway tract infection causes a 1 millimeter section of edema, the cross-sectional area is reduced to 5 square millimeters, and that's only 35% of normal. So airway edema can be a problem, particularly in the pediatric patient, and this can show the value of a drug a steroid like dexamethasone, as I mentioned earlier. Now, the first issue at the time that stridor occurs is whether intubation is necessary or not. If intubation can be delayed, several potential options can be considered depending on the severity of the situation. Option number one is expectant management with full monitoring, oxygen by face mask, and positioning the head of the bed for optimum conditions, typically 45 to 90 degrees. Our second non-intubation option is nebulized racemic epinephrine, 0.5 to 0.75 ml of 2.25% epinephrine added to 2.5 to 3 ml of normal saline. Cocaine in a dose not exceeding using 3 mL per kilogram can also be used, but not together with racemic epinephrine. And cocaine is something that we're using less frequently, even in ENT anesthesia. The next use of dexamethasone or Decadron 4 to 8 milligrams IV every 8 to 12 hours can be useful. And this takes time to work fully, which is the disadvantage of this technique. And finally, we have Heliox, a mixture of 70% helium, 30% oxygen. The result is almost instantaneous, and I have a case presentation based on this. I had, about 15 years ago now, a 58-year-old patient with recurrent head and neck cancer. She had limited mouth opening. She was very difficult to intubate using fiber optic bronchoscope, and even working in conjunction with the ENT team, they had trouble, but they did the surgery, and then there was stridor on extubation. The patient was starting to get agitated. The stridor was treated by 2 doses of dexamethasone, 2 doses of nebulized racemic epinephrine, and assist mask ventilation with the patient sitting up at 60 degrees. On standby, we had every available piece of equipment, an experienced ENT surgeon, experienced anesthesiologists at the main desk, and everything we needed for a surgical airway. We were ready for whatever came our way. But unfortunately, the patient did not improve, was starting to tire, and reintubation would have been even more difficult than it had been earlier, and earlier we had quite a struggle with it. It looked like a surgical airway was going to be our only way out, and we were worried. What saved us was a mixture of helium 70%, oxygen 30%, delivered using a non-rebreathing face mask at 10 liters per minute. Within 5 to 10 breaths, the stridor vanished, and the patient's work of breathing became manageable. This was in seconds, 5 to 10 breaths. The patient was then brought to the recovery room with a large Heliox tank in tow, full monitoring, and she was weaned off the Heliox over several hours as the dexamethasone did its job in reducing edema. So airway obstructing conditions such as epiglottitis or tracheal stenosis may be viewed as breathing through an orifice, defined as involving flow through a tube whose length is smaller than its radius. Gas flow through an orifice is always somewhat turbulent, and under such conditions, the approximate flow across the orifice varies inversely with the square of gas density. This is in contrast to laminar flow conditions where gas flow varies inversely with gas viscosity. And here we can see comparing oxygen, helium, nitrous oxide, and other gases, showing the various densities. And you can see the helium at a density of 0.178 grams per liter is much more favorable than compared to oxygen at 1.4 grams per liter in order to reduce turbulent gas flow. So take-home messages. Extubation protocols are available to help with decision-making for use in difficult cases. Extubation over a reintubation catheter can be life-saving. Heliox for delivery using a non-rebreathing face mask should be available in every operating room suite. And that brings the end of our discussion. Thank you very much for your time. And again, I apologize for the technical difficulties we encountered. I would remind also everybody that if you need a copy of the slides, simply write me on the internet, djdoyle@hotmail.com, and I would be glad to send you a copy of the slides, djdoyle@hotmail.com. Thank you again for your time, and I would invite any questions now or at a later time. Thank you.
Thank you very much, my dear friend, Professor John Doyle. This was an excellent lecture, and it deserves the waiting, and it deserves waiting. It's worth waiting for, actually. Thank you very much. I think we will delay the questions till the end, we will go directly to our next speaker, Dr. Rajesh Chandra Mishra. I hope I'm pronouncing the name rightly.
Yeah.
Dr. Rajesh, he has MBBS and MD in medicine. He's a fellow of the National Board in Critical Care Medicine. He has a European Diploma of Internal Care Medicine. He's a fellow of the American College of Chest Physician. He's a fellow of the American College of Critical Care Medicine. He's a consultant intensivist and internist in Ahmedabad in India. He's a Khayati multi-specialty hospitals in Ahmedabad. He is now, I don't know since how long, but newly appointed as a president of the Indian Society for Critical Care Medicine. And I would like to congratulate you on this. And now we know somebody very important in India, so we can come and attend your meetings. He's a chancellor of Indian College of Critical Care Medicine, and he's a managing trustee of Critical Care Society in Ahmedabad. And he's a national representative of India in the European Society of Internal Care, Intensive Care Medicine. Dr. Rajesh Mishra is going to talk to us about managing the difficult airway in ICU patients. And we are really looking forward to hear his excellent presentation.
So thank you, Dr. Salabi, and thank you, Dr. Saad, for this kind invite. And one of the very important subject, very close to my heart, because one of the important factor in contributing to the mortality and morbidity in ICU patient, and the incidence, prevalence, and the incidents are very high if the total care or a bundle or a specific approach is not being followed. So we are very quickly going to look a little bit about the airway in adult and pediatric setup, and then we are going to find the cause of difficult intubation, which will be like in our setup, it will be difficult, different from what routinely say in anesthesia table. We're just going to learn a little bit about the goal of intubation in ICU patient, and then how we manage or what expectation we have for this difficult airway in ICU patient. So the upper airway anatomy, which you know much better than anybody else will know. But for ICU, it is not the only anatomy. Rather, physiology of upper way and lower way also important, because it's a physiological change which causes the contributes to the maximum problem during intubation in ICU patient. All the ICU patients, one of the key problems are that they have got very low physiological result. They are in distress. So practically every patient in acute respiratory failure who comes to ICU or who needs intubation, they poses a challenge as difficult airway because they do not have a reserve, they do not have a time to break, and do not have indefinite time to find airway and intubate. And that really puts us in a challenging situation. Little bit of difference between the difference about the pediatric airway and adult airway. What we need to know that the shape of the pediatrics and neonates are in funnel shape. They have larger tongue in comparison to their space of mouth. Their pharynx is smaller, and even the tracheal rings are very small. And that precisely reason we need to know the age and what kind of tube they need. Most of the time, these patients need not cup tube, but we have to always be ready that neonates or pediatric age group can present to you with a special challenge. I personally do not practice pediatric intensive care, but we all must know, because many times you can come across a child who are younger patient who needs intubation. So a little bit of the anatomy we must know. The biggest challenge which we face in ICU, either by induced sedation or when patient is distressed or drowsy, that a physiological airway obstruction due to the loss in muscle tone, and this leads to a kind of choking sensation and hypoxia. A very simple measure, just lifting the chin or opening the airway, relieve this obstruction, which all must know, keeping in mind that if this patient has cervical injury, you have to thrust the jaw up, and if there is no cervical injury or there is no trauma, then you can just open and lift it. You can always put airway, keeping in mind if patient not having coagulopathy or not breathing very smoothly, just keep the airway open if patient is breathing spontaneously till you are able to definitely secure the airway. For patient who are little drowsy, where you want to avoid intubation, a nasal airway is an alternative. So first thing what we have to remember, that airway in operation theater and airway in ICU is a totally different scenario. And why it is so, I'll come to later, but we must know that while the death or hypoxic brain damage or surgical complication, in one of the largest trial from largest database analysis has shown, while mortality rate is 1 per million in a patient who are surgically intubated or in a planned way in operation theater, but when it comes to the ER or ICU or away from operation theater, the risk of this sudden death or cardiac arrest is 1 in 50. Most common cause is hypoxemia, and one of the most important contributing factor is secondary to esophageal intubation. That means a significant number of patients during intubation in ER or emergency ICU die due to hypoxemia or has a disability, and particularly this happened due to esophageal intubation. We also need to know that a certain group of patients, they are higher risk of cardiac collapse and arrest if they are elderly, they are breathless, if the intubating person is young, has not taken appropriate training and precaution, has not done enough pre-oxygenation because they do not have any oxygen reserve. The risk goes to the arrest if BMI is high, we have no oxygenated, and a patient is elderly. One of the most important, this list is exhaustive, I'm not going to read the list, but one of the most important reasons for hypoxic post rapid sequence induction hypoxia or hypotension, we need to remember, and because they are reversible, while esophageal intubation and malposition of the tube is the important cause. In cause for hypotension is hypovolemia or raised intrathoracic pressure, and that's the reason you need to pre-hydrate the patient, pre-oxygenate the patient, intubate under vision, and for raised intrathoracic pressure, you need to ventilate them with low tidal volume more frequently. So these are some issues which we need to remember when we are intubating this patient. As I said that ICU patient poses a challenge different from the OT difficult airway or airway which you can assess, is a physiological challenge. And if we start to see a different tidal volume and capacity, the most important issues which you have to remember is the functional residual capacity, particularly expiratory reserve volume. This is something which reduces drastically in a patient who are hypoxemic or in hypoxic refractory failure. And because of this low reserve, you do not have that much of time to intubate this patient. This patient needs to be pre-oxygenated well and well prepared. And in less than, you can hold one breath. Before that, you need to intubate this patient and secure airway. Not only this physiological change due to respiratory distress, this factor gets further complicated according to the position. If memory is supine, this further FRC further reduces. Elderly has reduced FRC because of the non-compliant chest wall and aging lung. Some ethnic group has, because of the size and because of the weight, has a different lung capacity. As you become obese, your lung capacity further reduces. And if you have a, if your height, if your long or if your height is above certain normal, this further contributes. So we have to keep all these factors also in mind when we are managing airway in ICU patient. As we age, our our lung compliance reduces, our resistance increases, as well as elasticity reduces, residual volume increases, but the total FRC is not changed much, but expiratory reserve volume is already low, and your closing lung volume is goes up. All these factors contributes to the more complication when we are managing airway in this patient. If we have to quickly look to that, while there is a normal breathing pattern of a normal person, when somebody has got increased resistance, that is the peak expiratory flow is raised, and when somebody has a problem of decreased resistance but compliance problem, then their FPV1 reduces. What it leads to that to generate a certain category, somebody has to increase increase transpulmonary pressure more, and that further leads to the complication. So what I'm trying to emphasize, in different disease condition, patient has a different FRC and expiratory residual volume. And this is one of the most important reasons when we intubate this patient for contributing hypoxemia and causing hypoxia and associated brain injury or cardiac arrest. So depending upon the patient condition, age, you should have certain background knowledge of patient anatomy and physiology. What is the condition when you are going to intubate? And then you take decision. That's why intubation in emergency is a planned, well-trained, and well-approached teamwork. It's not one person job. So critically ill patient has a two kind of difficult airway: physiological difficult airway and anatomical difficult airway. Physiological difficult airway in respiratory distance leads to reduced FRC. Anatomical difficult airway, because these patients do not allow you to traditionally assess the airway the way you do in normal patient who are cohesive, who follows your command, and where you can assess and pre-plan. So for us, in acute respiratory distress, all patients have difficult airway, and we have to be ready to follow the cannot intubate or cannot oxygenate protocol in every possible patient. And having so, when we face, we do not have to rush, we do not have to run, other than we are prepared on bedside to handle this situation. So what has been found that in critically ill patient, this one of the largest audit has shown that in generally people do not anticipate difficult airway because of the poor assessment. There is a poor planning, and there is a failure to modify the plan when they come across the difficult airway, anatomical difficult airway. This happened because the poor assessment, poor judgment, and poor anticipation. So if we go by the assessment method, which is generally followed in day-to-day practice, which is being taught in anesthesia practice, that do not apply in ICU patients. And even trials has shown, observation has shown that patient who needed the direct laryngoscopy in EI, 1/4 patient were unable to cooperate. 3/4 patients do not cooperate. And it was also found in large studies that 2/3 of these patients who developed cardiac arrest, they did not need Malampatti scoring or neck mobility testing, all these things, rather than they needed something else. So what I wish to emphasize with this observation, that when patient comes to an acute respiratory distress, there is something else which you have to do. You have to preempt, prejudge, and prepare yourself to handle a possible difficult airway, rather than going assessing and wasting time, rather than giving him oxygenation, pre-oxygenation, and improving lung capacity, and preparing yourself for difficult airway assessment. One score, Makocha score, this score has got very good predictive value of around a negative predictive value of 98%, but positive predictive value of 36%. Means if you have a high score, there is a likely chance that you will have a difficult airway. But the score is low, it doesn't mean patient will not have a difficult airway. This again is a complicated scoring system, but has been verified in ICU patient that higher score has got around 73% sensitivity, 83% specificity, and negative predictive value of around 98%. But positive predictive value is not that high because it's very specific. So when we go to intubate patient in difficult airway, there can be chance that there is a failure to visualize in direct laryngoscope. And most commonly nowadays, visual laryngoscope is being used. Even you can visualize, but you cannot pass the endotracheal tube. And the contributing factor to these are particularly if you're not able to pass airway edema, blood in airway, cervical spine immobility, very obese patient, a small mouth opening. So all these factors can be there, and how to handle this patient without wasting much time, without causing hypoxic injury, we have to prepare ourselves. So preparation for endotracheal intubation, patient positioning, and rapid sequence induction and intubation is the most important step which we all have to master for intubating these ICU patients. There are certain mnemonics which is being used for preparing, but in general, every ICU should have a very well-planned crash cart for managing difficult airway. It should be checked as a checklist, and all the gadgets, right from the suction to endotracheal tube to the laryngoscope to LMA to the buoy to the direct laryngoscope and including video laryngoscope, everything should be ready whenever we want to intubate any sick patient, including invasive and non-invasive device for ventilating these patients, including medication to prevent the arrest, including medication to hydrate, and including a team if a possible cardiac arrest happens before it causes hypoxic injury for good cardiac massage. COVID-19 has also just different airway management protocol came during COVID for protecting ourselves. But it's not COVID-19. Many times, some of the viral hemorrhagic fever comes, which is highly contagious, and we have lost few of our doctors. So all the patients whom we are going to intubate and we do not know about the nature of disease and onset is sudden, we should always try to protect ourselves by appropriate burning and appropriate using mask and gown and cap. So we should not get infected. And if you are in the mid of any pandemic or respiratory failure, particularly influenza or COVID-19, better to use at least N95 mask to protect yourself. So always protecting yourself before you go to intubation. I think main person who's intubating is also important. These are the protocol and these are the kind of covering we have used during COVID-19 initially. Later on, we came to know that N95 mask is 295 and negative pressure room is fair enough, and this was removed. So the thing is, you have to have a good team approach and protocol for intubation in ICU. There should be a pre-intubation prepare that contains of the presence of at least 2 experienced operators, fluid loading, preparation of sedation, short and long sedation, pre-oxygenation at least for 3 minutes with non-invasive positive pressure ventilation. Many a time in a patient who in acute hypoxic failure, if you have given high flow nasal cannula or nasal NIV ventilation, any patient is distressed, that can be continued till you prepare for the intubation. But when you remove, at least you should have be prepared with bag mask ventilation, because bag mask ventilation always gives you better control for ventilation than any other devices. During intubation, you should be ready for rapid sequence induction, what it is. There has been a little bit of the controversy and recommendation about the Selic maneuver. Selic maneuver is being used to prevent the aspiration. The risk of aspiration does not happen with everybody, but if patient has taken recently, and if you think that patient has got a risk of aspiration, or if neck can be not mobilized, then what can be done? That we put a hand below neck, fix the neck, and we give the pressure over required cartilage to prevent the aspiration. There has been a lot of controversy. If you think it helps, you doesn't think. But most of the time, it is not being practiced until the risk of aspiration is very high and you are preemptive about it. Post-intubation confirmation of tube by capnography, though it is time demanding, and some of the hospitals do not have. and it's gradually being replaced by handheld ultrasound. How it is, I will tell you. Always ready with norepinephrine, and in fact, bolus short-acting norepinephrine and phenylephrine are also being used in some of the patients who develop hypertension, just to prevent the cardiac arrest in these patients. Post-intubation, a maintenance of sedation and protective ventilation. The first thing about the position, when we intubate this patient, there has been always a fight or discussion about what kind of position is RAM position or sniffing position. I personally prefer a sniffing position, which gives me a direct access to the trachea and better visualization, where there is a flexion over the cervical and there is extension over atlanto-occipital joint. You have to be very, very careful this when you are giving this position in patient who has got head injury, trauma, and suspicion of cervical spine injury. This position cannot be made in this position where you have to keep the neck flexed. You do have to immobilize the neck. So you need a difficult. So whenever cervical spine injury comes, it itself challenges the intubator with a difficult airway. But the first thing, otherwise, in all the patient, sniffing position is a preferred position for intubating patient. And this is a fluoroscopic view of how the cervical spine moves when you maintain a sniffing position. If patient has got cervical spine injury, you need to maintain an inline axial stabilization. Here, select maneuver is needed to improve the visualization of the cord and helping intubation as well as preventing aspiration. You also need to give IV anticholinergic to prevent cardiac arrest due to vagal tone, because cardiac arrest during cervical spine injury is very common due to high vagal tone. So, if you have a cervical spine injury, as I said, that inline stabilization, intubation, preferably under direct laryngoscopy is preferred. Even boogies can be used. So, what we need to do, that we need to give, till we are ready for intubation, we need to give it enough pre-oxygenation. Why enough pre-oxygenation? Because all these patients have got reduced FRC. You need to preferably use BMB, but there has been like thought also that you give bag mark ventilation versus no ventilation. But when you do that, risk of hypoxic brain injury high in a patient where ventilation is not done. So all the patients who are less than 50, who are done by the non-trained person, raise, and if the cause for the hypoxic intubation is hypoxic respiratory failure, if saturation is less than 94% to begin with, and BMI is high, all these patients has high risk of intubation, high risk of intubation, hypoxic injury, intubation failure, and we need to be careful. So all these patients need to be given enough pre-oxygenation before we start intubation. Pre-oxygenation modality, non-invasive positive ventilation versus HFNC. HFNC and even HFNC can be combined with non-invasive positive ventilation. Post-intubation, recruitment maneuver has also been done to prevent the hypoxemia, because due to the respiratory distress and due to the reduced FRC, this patient has kind of physiological atelectasis, and we need to do the recruitment to improve the hypoxia. As I said, select maneuver does not prevent aspiration, may delay intubation, so should not be practiced routinely. We have to use the optimal use of pharmacological agent for avoiding coughing, avoiding farting, and relaxing airway completely, so we can visualize airway and intubate. But when we are doing that, we have to know that patient is totally dependent on us for ventilation. So we need to ventilate properly, we need to oxygenate properly, and after that, in one go, we should try to intubate this patient. Most of the time, because this patient has hypotension, until there is a hypertension and cervical, there is a traumatic brain injury. Otherwise, etomidate, or if patient is hypotensive, ketamine remains drug of choice for induction. Even phentyl-midazolam also can be used for induction. But the most important that nowadays rocuronium is replacing succinyl choline, because succinyl choline has got high risk of cardiac arrest in a patient who has got hyperkalemia, where you don't know the status of the particularly potassium. So just to avoid that, rocuronium is very safe. Only thing we have to remember that the dose of rocuronium for induction helping intubation is 1.5 milligram per kg to get the good result. All these medicines are short acting, and most of them the effect goes off in 2 to 3 minutes, and that's where if you fail to intubate, at least you can oxygenate them for 2 to 3 minutes, and that's precisely the reason we do not use any long acting drug. So we need a drug where onset of action is short, immediately, quickly, and the effect lasts for 2 to 3 minutes, not more. One of the important effects we have to always remember that myocardial suppression, reduction in cerebral blood flow, intracranial pressure, cerebral blood flow, and even oxygenation is important issue with all these drugs, and that's precisely the reason we have to always pre-oxygenate, give enough fluid, always keep a sort of the short acting noradrenaline or adrenaline or phenylephrine with us if patient develop, and then when we induce, we have to always ready with monitoring of with this medicine. As I said, post-dose vasopressor should always be ready and should be part of our crash cart when we are going to intubate this patient. Phenylephrine has to be used if patient has hypotension with tachycardia, and if patient has hypotension without tachycardia, then epinephrine remains the drug of choice. Normally, we don't have to give more than like 100 microgram per ml dose or 10 microgram per ml dose, and like 1 to 2 ml dose, like 100 to 100 microgram of phenylephrine, or 10 to 20 milligram or 20 microgram of the epinephrine is enough as a pushover dose for vasopressor. So, what is the current concept in tracheal intubation in ICU? First thing about the what recently it has been seen that most of the ICU are replacing direct laryngoscopy with video laryngoscopy. Direct laryngoscopy, the advantage of video laryngoscopy that at least you can visualize the epiglottis and opening clearly, but it doesn't. It's a time consuming, and it needs appropriate training of the person. If it is not so, then because most of the time the newcomers are trained with direct laryngoscopy and video laryngoscopy, they do not have access. This can itself can sometimes create problem in first pass attempt, and they fail to intubate. And even during intubation, if they cause any trauma of upper airway, that can complicate the issue further. And this is more common in a patient who come to us with a medical condition, particularly if they have sepsis, DIC, or multi-organ dysfunction. So as with any procedure, if you are too much interested for video laryngoscopy, you also need to train and follow the appropriate protocol for this. So how we intubate? We head up the patient position, particularly I prefer sleeping position. Working equipment should be ready. Though there is one main operator, but there should be always a backup of the second person. You should have all the gadgets to handle difficult airway, including the cricothyrotomy tube. Handheld ultrasound is nowadays a good help for managing difficult airway in ICU patient. You need to go for the, if you can do the scoring system. And during this time, while you are preparing yourself, you keep on oxygenating, prepare yourself, keep on oxygenating, hydrate them well, induce them, monitor them well, everything should be ready. And if the score is less than 3, direct laryngoscopy is good with the help of stillate or malleable tube. If score is more than 3, that video laryngoscopy is a good option. What is the most important thing that once you have intubated the patient, after immediately inflating, you need to confirm the tube. So if capnography, for successful intubation, capnography is the best tool. But nowadays, if you have a handheld ultrasound, you can confirm with better sensitivity and specificity with handheld ultrasound that you are in trachea. Not only that, you can even confirm that you have gone further or you are at appropriate place. So handheld ultrasound is gradually replacing the even capnography for confirming the tube position and even positioning of the endotracheal tube. This is how the capnography will take 1 or 2 breaths before you can see, or you have to connect the patient to the ventilator. But what you get in ultrasound, that when you are in trachea, you can see the tracheal ring and you can see the tube, there is a gap, and there will be only one sign. But when you go in tube, the tube will appear here, another black dark hole or dark aperture appears. So when you have second dark aperture, double halo sign appears, that means you are definitely in esophagus. You immediately need to remove. So this you are doing online while intubating. You don't even need to connect for the endotracheal EtCO2 confirmation unless you have confirmation connected the EtCO2 into online. This is also time saving, and in time it tells you that you are in wrong position, you need to adjust your tube. And that's the reason handheld ultrasound is gradually replacing the EtCO2 for monitoring the positioning of the tube. Apart from that, with handheld ultrasound, very quickly we can also assess the difficult airway. We can also assess the cricothyroid membrane if surgical has to be done. We can identify and appropriately puncture it, and we can even prevent the aspiration ring just looking to the stomach content, and we can do the Selig maneuver to prevent that. One of the important thing about the finding the difficult airway, although it's in pilot phase, but skin to epiglottic distance, if it is more than 30 millimeters, is one of the very high predictive of the difficult airway in a patient who is respiratory distress. So probably ultrasound is going to help us in more and more. As I said, that intubation is highly related to the human factor and team behavior. So repeated training, appropriate team builder, repeated training with the and certification by different agency is one of the key factors for reducing the complication related to airway management and HVAC. So what happens if you cannot intubate or cannot oxygenate? It's called SICO rescue, and the vertex approach is being proposed for it. Initially, you give bag mask ventilation. You try to intubate with airway. If you are not able to do it, again you take on bag mask, again try, but do not attempt more than 2 times. In the meantime, you call for better help. And if you have failed 2 times, better to go for the laryngeal mask airway, oxygenate the patient well, get better person to come, prepare yourself for the managing difficult airway, till that you do not compromise with hypoxia. What happened during this time, we try to intubate so desperately that we forget to use LMA, and we forget to use that we can even oxygenate without intubating the patient without causing further damage. So if we just remember this vertex approach for the patient where we find that the airway is difficult, we are not able to visualize, other than causing trauma, injury, bleeding, and making the airway difficult, we should try to oxygenate, equip ourselves better, get better person on site, and even prepare ourselves for surgical and surgical intervention. And if we cannot intubate and cannot oxygenate patient, then cricothyroid, mini cricothyrotomy, functioning of the cricothyroid membrane with cricothyroid set, or even with needle and oxygenating through that, jet ventilation or through oxygenation is the other option for securing the airway. This is how you secure the LMA and oxygenate the patient well. Many a time you come across with a condition where you should not sedate the patient, because the moment you sedate, you take away the breathing efforts of the patient, and very likely the patient will become hypoxic and die. Particularly if a patient has very severe cervical spine injury, very severe, there is a mass in like fixed cervical spine due to the ankylosing spondylitis. There can be case of the big thyroid goiter and the thyroid disease, a very obese patient where neck is not visible and unstable cervical spine. These are the patients who even can be tried with awake intubation, with intubating ground, or with the help of local application of anesthesia. So we should also remember, and particularly if patient is developing stridor, these are the patients, if you try to sedate, the moment you sedate, they will arrest, because their airway will collapse, their vocal cord will collapse, and you will not be able to even pass through that. So particularly in patient who has got stridor, we should not try to sedate or paralyze, other than try to do awake intubation. So this is how you do the awake intubation. With even nasal intubation can be tried with enough local anesthesia. just put a railrolled endotracheal tube over bronchoscope and go through the nose, railroll it over and pass through the tube. What is our goal to achieve? What is our goal? The goal to achieve 100% perfection, because we know that the risk of hypoxic brain injury or brain death or cardiac arrest is very high if the intubation is not appropriate. So no hypoxic injury. We should have first pass intubation, success rate 100%. That's what ideal goal, and 100% physiological optimization. That's what we want to achieve in intubation. So with this, thank you. Thank you for your attention. I have taken appropriate time and I'm happy to take it.
Thank you very much. Thank you very much, Dr. Rajesh Mishra, for this outstanding lecture. And I can see that the feedback is extraordinary, really. Now we know why you're the president, the new president in the Critical Care Society. It's my pleasure now to introduce Dr. Yash Jafiri. Do I mentioning the name rightly? Dr.
Yes, sir. Yes, Professor.
Thank you. Dr. Yash Jafiri has his training in critical care medicine. He has an Indian diploma of critical care medicine. He's a fellow of the Indian College of Critical Care Medicine. He's a past chairman of the Society of Critical Care Medicine in Delhi. He is now the head of critical care and emergency medicine in Regency Super Specialty Hospital in Lucknow in India. He's a convener of the Indian Sepsis Forum and the vice president of the Indian Society of Toxicology. He's a vice president of the Society of Neurocritical Care, and he's a COVID Medical Task Force member, and he's an advisor for the Healthcare Sector Skill Council. He's going to talk about a very important subject, adding to today diversity in airway management. He's going to talk to us about airway in trauma and how is it different. This should be a very interesting talk, and the floor is all yours, and we are waiting for this excellent presentation. Thank you.
Thank you, Professor Medahat Salahi. I'd like to thank Dr. Saad, also the Mecca Academy, for the kind invitation. My job is done easier by Professor Doyle and Dr. Mishra. Many core concepts have already been explained. I'll be talking about airway in trauma. What are the intricate differences from the routine airway in ICU? Disclosures, no conflict of interest. The learning objectives from my presentation will be to understand the peculiar issues in trauma airway, the non-airway issues in trauma airway, what are the challenges, how to safely intubate a trauma victim, a checklist approach, and what are the pitfalls which we commonly face during trauma airway management. For a trauma patient with an unprotected airway in the emergency, the end goal is a definitive airway, which is reached through various algorithms and methods depending on the experience of the provider. You have to remember, it is important to adequately assess patient prior to intervening, make a quick decision about need for a definitive airway, have all of the necessary equipment and medications at the bedside, and have a very specific plan. In the event, the airway becomes increasingly more difficult to achieve. So first pass for airway, it is easier. More you try, difficult it becomes most of the time. The plan is different for every provider, depends on their resources, their training and experience, which needs to be modified on a case-to-case basis, depending on the clinical context. However, it's a teamwork, and everyone in the airway team, especially for a difficult airway, should be aware of a common plan, what is happening next, and They should be able to assist in implementation for a high success with a definitive airway. Now, what are the common concerns of airway in trauma? We know loss of airway always kills. So airway always comes first. ABC, A is first. It's a time-bound intervention specifically for trauma. If we talk about stroke, we talk about MI, they give us time for airway intervention, but trauma does not give us time. Airway control is required not only for airway related or altered sensorium in trauma, but also for multi-system and critical trauma. Airway injuries like maxillofacial or laryngotracheal are challenging. Airway injury could be primary, as is seen in this picture, or it could be secondary. You are using a bougie. Earlier, you were using metallic stillets. Endotracheal tube can injure. There's a foreign body which can injure. So there are multiple reasons of secondary airway injury, especially in trauma. You are using a measures forceps that can also injure. So you have to be very, very careful, especially if it is a difficult airway. Many times, the emergency physician is able to intubate. At times, you are called as an expert. So you get a second-hand airway. So a second-hand airway is obviously a difficult airway, and multiple trials have been done. So bleeding, swelling, vomitus could be a bigger challenge in second-hand airway. A always comes with C in trauma. C stands for cervical spine. C also stands for circulation. Whenever you find anything wrong, you go back to A, B, C. If you found anything wrong in C, again you start with A. So airway is a big challenge in trauma and a big priority in trauma. We avoid nasal intubation, especially in maxillofacial or base of skull injury, or with coagulopathy in trauma. There are many distractions in trauma. Injuries like this, open abdomen, mutilated limbs, this distract you, but you should be focused, and your cognitive functions also matter while you are dealing with a difficult airway. Patient cooperation, at times patients are agitated, combative, so these are major issues in trauma. So issues could be related to airway per se, or it could be other physiological issues or trauma related issues in a trauma airway. So you can have an anticipated difficult airway. By very nature, most of the trauma airways are difficult airway, but it could be unanticipated difficult airway. You found something unexpected. So what are the other concerns? Altered mental status, combative patient, it's difficult to assess the airway. Bleeding, vomitus, foreign body. It could be denture, it could be debris from trauma, it could be glass particles. These are challenges. Swelling, swelling in the airway, swelling around the airway. Both are challenges, it compromises the airway. Blood and difficult airway, this is a vicious cycle. It's a difficult airway, you do few trials, there are some oozing of blood, it becomes more difficult. So bleeding in the airway and around the airway, both have its own implications. Vomitus, aspiration, critical hypoxia by aspiration or by other causes, by contusion. So airway is a dynamic process in trauma because the disease is evolving. The swelling is evolving, the bleeding is evolving, so it's a dynamic process. Delayed issues, if you delay in definitive airway, the outcomes will be bad, it will be difficult to handle. Patients with reduced level of consciousness have priority airway, and similar is the case with majority of multi-system trauma patients. So trauma airway is always emergent. There is some degree of panic, especially if there is maxillofacial or laryngotracheal injury, neck and spine concerns, hypoxia, raised ICP, raised intraocular pressure are concerns. RSI can decrease the chances of success in intubation, and environmental factor we should not forget. At times, you might be intubating a patient on the road, you might be intubating a patient in a car, restrained space. You have to look for your safety also. The scene safety is important. So it's a tightrope walk. Combative patients, altered mental status, excessive movement and struggling will not only raise ICP, it can exacerbate spinal injuries and cause excessive movement at fracture sites like pelvis fractures. and increased bleeding. So a combative, uncooperative trauma patient is a difficult patient airway-wise. Often, there is a pressure to clear the C-spine and your focus is on a different injury. This leads to inadequate imaging and the consequences can be disastrous. Typical intubation methods can be difficult or at times impossible in patients with rapid oropharyngeal bleeding, reduced oral access or laryngotracheal injury. In such circumstances, you have to take a balanced approach, risk versus benefit. If the risk is more, you wait, you call the specialist, have your full team there, utilize other measures like LMA or PTJV, whatever comes handy. Ultimately, it has to be an individualized and personalized plan for that particular patient. Timing is everything in life, and airway in trauma is a time-bound process. It is well known that delays in adequate airway management are one of the most common causes of preventable death, both in pre-hospital setting and also in the ED. Even for patients that are initially stable, a delay in intubation is associated with an increased mortality, 1.8 to 11.8% in one of the studies. So you understand, not only it will cause morbidity and mortality, also it can become more difficult. So do it urgently, but not hurriedly. Trauma-based intubation has to be practiced, rehearsed, planned, have team. Pre and post procedure checklist has to be followed. Most important, practice. Do it in a time-bound measure. And you should do a review of difficult airway practice. At times, you might not be able to do an intubation. Then you have to look at the root cause analysis. What went wrong? Next is assessment. How do I adequately assess the airway for trauma? While many emergency intubations are routine, as many as 0.3 to 2.7% can result in failed airway in the setting of trauma. Difficult bag mask ventilation, these are the routine risk factors: facial hair, obesity, edentulous advanced aging, snoring, and oromaxillofacial trauma. Difficult direct laryngoscopy, obesity, short neck, small or large chin, buck teeth, high arch palate, and any deformity related to trauma, inflammation, tumor, or swelling. Obviously, assessment is advised, but many a times, critically ill trauma patients won't give you time for assessment. No specific recommendation which method is best. East Guidelines Level 2 recommendation to use a standard assessment tool, which is Lemon, and to use neuromuscular blocking agents with caution when significant difficulty is anticipated. We all are aware of Lemon. Look externally, evaluate 3, 3, 2, malampati, obesity or obstruction, and neck mobility. Obviously, neck mobility is an issue in the multi-system trauma patient and head injury patient. So what are the three main indications for emergency intubation? Failure to maintain or protect airway, failure of oxygenation or ventilation. These are obvious indications. Even a fresh resident in training will understand. However, this third indication is where we go wrong very often. Is there a need for intubation based on the anticipated clinical course? And we as consultant have our training and obligation to decide such patients where they need intubation depending on a bad clinical course which is expected. Which trauma patient should I intubate? Level 1 recommendation for airway obstruction, hypoventilation, persistent hypoxemia despite supplemental oxygen, cognitive impairment, GCS 8 less than 8 or 9, severe hemorrhagic shock, cardiac arrest. What is the pitfall here? Beware of multiple issues compromising airway. I'll give you an example. There is a patient with mild head injury, GCS is 12. Patient is coughing out blood, but as time passes out, his sensorium dips, he starts aspiration, his saturation level falls. So now you have two issues which are compounding the airway. And we have many such scenarios, especially in trauma. Level 3 recommendations: facial or neck injury with the potential for airway obstruction, moderate cognitive impairment, persistent combativeness refractory to pharmacological agents, respiratory distress, preoperative management. Early endotracheal intubation is for cervical spinal cord injury with any evidence of respiratory insufficiency. Persistently combative patients are a peculiar set of patients. Rarely we intubate the persistently combative patient in order to complete a thorough trauma evaluation, including imaging. Endotracheal intubation in these patients will lead to a longer stay, increased incidence of pneumonia, and a poorer discharge status when compared with matched control. So you have to have a difficult choice, often a dilemma, whether to intubate such patients if required. Smoke inhalation, facial burns, oropharyngeal burns, moderate to severe airway injury seen on endoscopy. Now you have decided to intubate. You have to intubate from the orotracheal route unless there is a specific indication for a nasotracheal or an awake intubation through the nasotracheal route. Very, very rare in trauma or an emergency. The exceptional rule. Now I want to intubate. What next? First thing is plan. The first priority is to prepare the patient for intubation, pre-oxygenation, place them in appropriate position, protection of patient, placement of tube, post-intubation management has to be looked into. Patient positioning can be a challenge, especially injuries involving airway, injuries involving spine, impalement injuries. So often we have to intubate them sitting, lateral position, prone position, we have done it all. Which drugs do I use? RSI is a level 1 recommendation in the East guidelines, with the exception of the presence of potential markers of significant difficulty with intubation. In this case, it may be recommended to attempt delayed sequence intubation or awake intubation. Objective of each drug in RSI is different. However, maintenance of hemodynamic stability, CNS perfusion, adequate oxygenation, no rise in ICP or IOP are important factors while we choose the right agent for intubation. Plan, pre-medicate, generous analgesia, induction, muscle relaxant. If we are intubating the patient who is unresponsive with hand injury, obviously the ICPs are high. So you have to have generous analgesia, right dose of induction agent, anxiolytic, muscle relaxant. Even the slightest rise in ICP can lead to herniation or raised intraocular pressure is another indication. Induction agents commonly used: ketomediate, rapid onset, hemodynamic stability, and extensive experience. Ketamine, some controversy, but people have been using, especially patients who are in shock. Theoretical increase in ICP. Fentanyl is my personal favorite. Low dose of fentanyl we are using for most of the patients. When to use neuromuscular blockers, when not to use is a difficult choice. It is a very difficult airway. We avoid using it. These guidelines do not make any specific recommendation which neuromuscular blockade to use. However, succinylcholine, because the shock-acting drug, is commonly used in absence of contraindications. High dose rocuronium, because it's again a fast-acting agent, is an acceptable alternative. The pitfall here, the blockade might last longer, up to 45 minutes. Dr. Mishra already pointed out about cricoid pressure. The pendulum has swung widely since the introduction in 1960s. Theorized worsening of laryngeal view upon application. So there is insufficient evidence, but if you are using it, you have to use it in the right way. A popular alternative to CP is burp, backward, upward, rightward pressure on the thyroid cartilage, not on the cricoid ring, to enhance the visualization of glottis, commonly used. Another modification is bimanual laryngoscopy. You can see with one hand, the intubationist is holding the laryngoscope, and with the other hand, he is adjusting the larynx. Then somebody else takes up. Direct laryngoscopy or video laryngoscopy. No specific choice, however, for spine injury, And raised ICP, often video laryngoscopy is used, but the training curve has to be adequate, and do not start using a new technique for the first time in an emergency situation. Circulation issues, always have two good IV access, one for drugs, one for management of shock. Failure to optimize hemodynamics in trauma for RSI is a big pitfall and a big killer. Resuscitate before you intubate. After induction and paralysis, BP can again fall, so prepare yourself. Airway trauma. What is airway trauma? It is an injury that directly involves the airway in any location from the nasopharynx to the bronchioles. It may involve actual damage to the airway or injure bony or vascular structure that distort the airway anatomy. So it could be directly related to airway, or it could be swelling like a neck hematoma. It could be presented in a very, very ghastly and distracting injuries. But again, your cognitive function, the teamwork, the team dynamics for a difficult airway works wonder. This is a lower airway injury and stab injury. So airway injuries we commonly see, laryngotracheal injuries are also not rare. They should be suspected in patients with blunt or penetrating injury to the neck or chest, especially with external evidence of injury like hanging, strangulation. Features could be pain, ecchymosis, swelling, or soft tissue crepitations. Although CT scans can detect roughly 90% of injury, bronchoscopy is the gold standard for diagnosis. So call for help if there is a suspicion of laryngotracheal injury, and best treated in an OR environment. Injury severity and treatment options can also be determined using bronchoscopy as well. Paramount in managing suspected partial tracheal transactions is to avoid converting the injury to a complete transaction. So the intubation has to be under vision, totally under vision, and you have to bypass the area which is injured. If there is a tracheal laceration, there is a gaping injury, you have to bypass that, otherwise there will be persistent leak. Positive pressure ventilation or an unguided placement of a large bore tracheal tube can complete a partial tracheal transaction. In these patients, successful tracheal intubation is best accomplished in the OR with a skilled fiber optic intubator. Tracheal repair can also be done simultaneously or as an elective procedure. Once you have intubated a patient, maintenance of airway is again important, especially if it has been a difficult airway. Bleeding and clotting is not uncommon. If your peak airway pressures are rising and suctioning is required very, very commonly, think about tube blockade. It's very common, especially after a traumatic intubation. Cuff pressure, you might have injured the cuff, very common. Difficult intubation, the cuff might be damaged by the teeth or by the stellate. If the airway pressures are going high or very low, you suspect there is a leak or there is a blockage. Malposition, dislodgement of the tubes. So you have to prevent complications. The tube should be fixed neither too loose nor too tight. If it is too tight, the ICP can raise, the venous return can decrease. You have to look for device-related pressure ulcers. So put your colloid dressing below the bandage. Always secure the endotracheal tube doubly, especially if the patient is being transported with the bandage and with the dynaplast or whatever adhesive you have been using. Check for fixation on every shift. Correct positioning is important. Flexion and extension of neck will move the endotracheal tube. So you have to check on every shift. Misplaced tubes, endobronchial intubations, biting of the endotracheal tube by patient, complete transaction of endotracheal tube, everything happens. At times, the patient has to be restrained with drugs and physically as well, depending on the patient. So once you have a definitive airway and the patient is with you, the A becomes artificial airway. Your assessment of airway never ends. Now the airway assessment will be for the artificial airway. You have to look for adequacy, whether it is secure, it is misplaced, displaced, whether it is safe for the patient, Are there any complications arising out of the airway? Is it blocked or is it patent? Risk of failed intubation in trauma is high, about 1 to 5% depending on the setup. Consequences of hypoxia are obviously catastrophic, so you need to have a plan B. Stopping is seldom an option with trauma. Surgical airway can be the first or best choice in certain conditions like maxillofacial injury. An awake endotracheal intubation could be chosen in a difficult airway patient, provided the patient is cooperative, stable, and spontaneously ventilating. Uncooperative combative GA may be administered, but if airway is difficult, spontaneous ventilation should be continued. So have your plans in place, plan A, plan B, plan C, and minimize your failure rate of definitive airway. Emergency intubation checklist, pre-procedure checklist, post-procedure checklist for the human resources, patient factors, drugs, equipment, and other resources, whatever have been required. Few dictums in airway: always start with A, go back to A. A also stands for artificial airway in trauma. Consider all trauma airways as potentially difficult. So better to do as elective, otherwise it gets more difficult. Be prepared for the worst, call for help. Change hands. At times you will be exhausted, you will have muscle spasms after trial, so change hands. If in doubt to intubate or not, intubate. If in doubt to do tracheostomy or not after a few days, tracheostomize the patient. Planned is always better. Do what you are best trained to do. In an emergency situation, do not try new techniques. Difficult case, start afresh. Do something new. Do not just repeat the same things. Do something new. Think, where have you been going wrong? If you cannot ventilate, intubate. If you cannot intubate, ventilate. At times, you have to make a difficult choice to intubate or not. As a consultant or as a senior person who is looking after trauma cases, you have to know when not to mess. If patient is maintaining saturations, it could be a very, very devastating injury like a cherry bomb explosion we always show in ATLS, my first picture. You have to wait. You have to have the right subset of people, have your full team there, have the OR and the senior most bronchoscopist ready for the intervention. The practice points from my talk are: trauma airway should always be a priority airway. Consider it difficult by virtue of being an emergency and trauma scenario. Optimize trauma conditions. Do what you are best trained to do. Have flexible, workable plans. Airway saves and airway kills. A always comes first. Use checklists, call for help. Have airway codes in your emergencies. Last but not least, airway management in trauma victim is not just management of airway alone. You have to look at the patient in totality. Thank you. Thank you, sir. Professor, hello. Yeah.
Yes, thank you very much. Thank you very much. That was outstanding as well. Very, very clear, very informative. And thank you very much for that. Now we are going to the youngest and most talented one. We are going to Muhammad Isa,
Yes, sir.
who is a lecturer in Ain Shams University in Egypt. And he is now in Canada, in Ottawa. He has a bachelor degree, master degree of anesthesia and critical care. He has doctor degree in medicine in anesthesia and critical care. He has a European diploma of intensive care medicine, and he's advanced provider of perioperative transesophageal echo examination in the perioperative settings. He's now a clinical fellow of obstetric anesthesia in the University of Ottawa in Canada. And he's going to talk to us about a subject which is new as he is, This is the time of our junior generation. He's going to talk to us about the airway ultrasound. And this is, of course, a very important lecture, and we are all excited to hear about it. Thank you.
Okay, thank you, Dr. Chalabi. Good evening, everyone, and good afternoon. Thank you as well, Dr. Mahdi, for inviting me again to be a part of this amazing work. I'm really happy to be here with you today. For those who don't know me, I guess Dr. Chalabi has already said, I'm already a lecturer of anesthesia and intensive care at Ain Shams University. I'm now doing a clinical fellowship in OB anesthesia as well at the University of Ottawa. So today I'll be talking about airway ultrasound. So through this lecture, I will try to discuss and outline the anatomy of the larynx and the applied anatomy and how it's related to our ultrasound scanning. I'll try to talk also about how to obtain our images, which probe should we use, and what are our scanning techniques. And also I'll be talking about some uses of airway ultrasound in our clinical practice, like in difficult intubation scenarios by identifying the cricothyroid membrane and by detecting inadvertent esophageal intubation and screening for difficult intubation as well. So as you see here, so the larynx is formed of a cartilaginous skeleton, muscles, membranes, and ligaments. So as regards the cartilaginous skeleton, it's formed of three main unpaired cartilages, big cartilages, which are for sure, you know, the thyroid cartilage, cricoid cartilage, and the epiglottis, which arises mainly from the back surface of the thyroid cartilage, as you see here. It also has three small paired cartilages, such as the arytenoid, corniculate, and cuneiform. And as you see here, the vocal cords are usually extending from the arytenoid to the back surface of the thyroid cartilage. So talking about the thyroid cartilage, it has mainly two big lamina, as you can see here, which meet in the midline and form a prominent angle, which we call the laryngeal prominence, or Adam's apple, as you can say. And the superior thyroid notch, as you can see here, and this is very important, as we will be seeing during discussing the ultrasound scanning for the thyroid cartilage. And then below it, you can find the cricoid cartilage, which is has a narrow anterior arch, as you see here, and a broad posterior lamina, which has articular facets on the lateral surface to articulate with the thyroid cartilage, and the superior also or some articular facets of the upper surface, which will be articulating with the base of the arytenoid cartilage. So for image acquisition, we need to know that we are gonna scan a superficial structures, so we can use a high frequency linear probe with less penetration power, which can give us the advantage of having a high linear resolution, high axial resolution. So for the uses, as we said, the existing literature have shown many uses of airway focus in managing difficult intubation by better identification and visualization of the cricothyroid membrane, and by helping us to detect the inadvertent esophageal intubation. And we all for sure know that airway management is considered to be the anesthetist and critical care physician's most recognized skill, and that the complication of airway management can cause and lead to a higher morbidity and mortality. So for the management of difficult airway, cricothyroidotomy is always or usually the last approach that we can use to save a patient's life when all other non-surgical approaches fail in cases of difficult intubation and difficult ventilation. However, the success rate of life-saving cricothyroidotomy by anesthesiologists is low, with a failure rates reaching up to 65%, as shown by the national, and here in this study, by the fourth national audit project by the Royal College of Anesthetists. And this is usually due to failure or difficult identification of the cricothyroid membrane by external visualization palpation. However, on the other hand, airway ultrasound can facilitate the identification of cricothyroid membrane, which in turn improves the success rate and decrease the time needed for cricothyroidotomy. So as you see here in these interesting studies, it was shown that using ultrasound has a better success rates in identifying the cricothyroid membrane. This can be done either, as shown by this study, by pre-identification and marking the cricothyroid membrane, as shown as in this study by Malin and colleagues, or by dynamic scanning during cricothyroidotomy procedure. And we will see how, for sure, I'll show you how to do this later on. So let's go to how to scan, scanning techniques. So we have two scanning techniques. The first one is called the TACA technique, which is a transverse scan technique, which is done simply by placing, as you see here, a high frequency linear probe in the submandibular area behind the mentum and just sliding it slowly downwards, as you see here. So when you slide it, you'll see what we call, we'll get what we call the TACA technique, which is T stands for the thyroid cartilage, which, as we see here, will be seen first. And as we said before in our applied anatomy, it's formed of two big lamina which are attached together at the midline, forming that angulated curve. So we can see it, or we can appreciate it as an inverted V-shaped thyroid cartilage or triangular cartilage, as you see here. And then when you go slowly caudally, you'll start to appreciate the air line or the air mucosal interface between for the cricothyroid membrane between the thyroid cartilage and the cricoid cartilage. And remember, the cricothyroid membrane or the air mucosal interface will always be a hyperechoic, unlike the cartilages, which is going to be a less echoic or more hypoechoic. Then when you go further down, you'll start to see the cricoid cartilage, which is more circular, as you see here, instead of being inverted, angulated V-shaped, as you see here for the thyroid cartilage. And so when you reach the cricoid cartilage, you should be moving your probe again upwards cranially or cephalade in order to get the air mucosal interface. So that's why we call it the TACA technique, which is thyroid airline, cricoid cartilage, and then slide upwards again to reach to the airline where you can identify the cricothyroid membrane. So these are some slides. So showing you here the hyperangulated or the inverted V-shaped appearance of the thyroid cartilage when you go slightly downwards. And then at some point you can even see the vocal folds or the vocal folds, which is, as we said before, would be extending from the back surface of the thyroid cartilage to the arytenoid cartilages. And then when you slide further down, you'll start to get into the cricothyroid membrane. And you can appreciate here the hyperechoic airline interface. And then when you go further down, you'll get the circular or the cricoid cartilage, which you see here, which is more hypoechoic, as you can see here. And when you reach that point, you should slide your probe slowly upwards to get back to, and here again, hypoechoic R-shaped cricoid cartilage. And when you slide back upwards, you'll get into the hyperechoic, or get to the air mucosal interface, which is more hyperechoic, as you see here, for the cricothyroid membrane. And just to show you, like if you slide further downwards, you'll get into the tracheal rings, where you can appreciate the presence of the thyroid gland, the isthmus, and the two thyroid glands here. So another way to scan, or another scanning technique, is the longitudinal scan, which we call the string of pearls, which is done simply by also placing a like a high frequency linear probe in a longitudinal approach, and by placing it. So the most difficult part of this approach is just to identify the midline. So once you identify the midline and you put the probe in a longitudinal axis, you'll be able to see, as you see here, first you'll be able to see the tracheal rings, which are, as you see, as we said before, always the cartilages or the rings would be hypoechoic. So the tracheal rings here are hypoechoic structures that can be seen along a hyperechoic line, which is the air mucosal interface. So these are the tracheal rings, and this is the air mucosal interface behind the tracheal rings. So simply by just identifying, placing the probe in a longitudinal axis and putting it in the midline of the patient's neck, you'll get that. And simply just by keeping the probe in the midline and just sliding it upwards, slightly upwards, you'll start to appreciate or you'll start to see what we call the cricoid cartilage, which is larger and more superficial when compared to the tracheal rings. So here are our tracheal rings, and this is going to be the cricoid cartilage. And then when you slide your probe further up, you'll start to see another bigger cartilage, which is still hypoechoic, as you see here. So cartilages, we should always remember that a cartilage is a hypoechoic, not a hyperechoic. So when you slide your probe further up, also in the midline, you'll start seeing a larger hypoechoic thyroid cartilage. And you can appreciate the membrane, the hyperechoic air mucosal interface, hyperechoic, which is the cricothyroid membrane, as you see here. So, and then you can try for identification, you can, like, just for marking your cricothyroid membrane, you can try to even slide, as you see here, a hyperechoic marker, let's say a needle, in between the transducer and the patient's skin. And as you see here, so this is a longitudinal approach. So we can see here the cricoid cartilage, the thyroid cartilage, and we can see the hyperechoic air mucosal interface of the cricothyroid membrane. And we can see here the marker, our markers that we're trying to slide in between the patient's skin and the transducer. So when we reach this point, and we can then try to mark the spot, and now we were able to identify and to mark our cricothyroid membrane in case that we need to do an emergency cricothyroidotomy in case of failed other non-surgical approaches in cases of difficult intubation and ventilation. And one other use for airway ultrasound, as I mentioned before, is detecting inadvertent esophageal intubation. So for sure, we all know that capnography is considered to be the standard of care for the primary verification of endotracheal tube intubation. However, airway ultrasound can be really helpful in situations where capnography is unreliable, such as cardiovascular arrest. And there was even some meta-analysis by Chu et al. That suggested that in situations where capnography may be unreliable, ultrasound can be helpful with a high diagnostic value and high for identifying esophageal intubation with optimal sensitivity and specificity. So how to scan? So in order to detect inadvertent esophageal intubation, we can do it like a dynamic scanning during the intubation by just placing the probe, high frequency, also linear probe, transversely just above the sternal notch, where you can see also in this study where they have found that determining endotracheal tube placement with ultrasound was found to be fast and high significant with a high significant utility in arrest situation where end-tidal CO2 was not reliable, as we said before. And also it was described in patients were in COVID-19 patients where considering, you know, you have your protective PPEs, and just to avoid spreading the virus by auscultation and potentially insufflating the stomach after unsuccessful intubation. So as we said before, just by doing dynamic imaging during intubation, you can appreciate the presence of the esophagus, as you see here. So this is the midline. You can see here your tracheal rings, and then you can find here on the left posterior part of the trachea, you can find like that hypoechoic area, which is considered to be esophagus. It's not easy to find, but definitely when you get a endotracheal tube inside the esophagus, you can really now appreciate the presence of that hypoechoic area of the esophagus, which, as you can see here, you can find two air-filled structures. First is the trachea, and the second is the esophageal intubation, which we call a double, as you see here, which is was described by Sahu and colleagues as being called double tract sign. So also there are some other uses for airway ultrasound. One of them is the screening for difficult intubation, which is still have some studies being going on in progress to try to look at the use of airway ultrasound for screening for possible difficult intubation by looking at many variables such as tongue base thickness and tongue width and distance between the skin and the thyroid cartilage and the hyoid bone as well. So these are some references that I have been I've used for making this lecture. Just for further reading, if anyone wants to read more about this topic. And thank you, everyone. And any questions?
Till Brochure arrives here. Mohammed, thank you very much. It was an excellent lecture outlining ultrasound in airway management, and I got a lot of praise about those lectures today. Airway module started with the legend Prof. Doyle and Dr. Mishra, and Prof. Hatchari will now take over. Thank you so much.
Thank you very much. I think the presentations were outstanding, and really you can see from the feedback that everyone is very happy for the presentations and how good they are. And now we are opening the floor for discussions. Any discussions, any questions?
I think we have two questions here, Prof. And the chat is clear. Just all praises the lecturers and the speakers and their time and their effort to come on time and get those lectures on the platform in the best way to be easy and the fascinating lectures. And everybody recognize the effort and the professionalism and enthusiasm to get this module delivered on time and in high standard. And we have access by more than 70 countries and more than 400 colleagues tonight. And thank you so much.
That's outstanding. Thank you. Thank you very much for everyone who participated in this
those lectures are going to be uploaded to the YouTube channel and www.bigalearning.online. And the subscription for both are free, and all you can join the 330 lectures previously loaded to the both platform. And thank you so much.
Thank you.
Thank you.
Have a good
From
night.
me and you.
Thanks a lot. Thanks, Professor.
Thank you. Thank you so
Thank you,
much.
Dr. Shah. Thank
Thank
you.
you.
Thank you,
Thank
Dr.
you.
Shah.
Till we see you again. Thank you so much.
Thank you,
Thank you.
Chairman.
Thank you, everyone, for the excellent opportunity and excellent talk. Good night.
Thank you.
Good